Welcome to the Radiology Review podcast, your on-the-go source for radiology education with your host, Dr. Matt Covington, a board-certified radiologist. Please follow the podcast on Twitter at RadRevPodcast. Send emails to theradiologyreview@gmail.com or visit the website theradiologyreview.com.
Welcome back to the Radiology Review podcast, your top free on-the-go source for radiology board review. This episode is the final of 3 episodes on nuclear medicine and the thyroid. On this episode, we will focus mostly on thyroid cancer and discuss many high-yield topics about radioactive iodine therapy of thyroid cancer and hyperthyroidism. I will make a free downloadable study guide on this topic available on my website, www.theradiologyreview.com, so please check that out if you are interested in that. As a reminder, you can also follow at RadRevPodcast on Twitter and Instagram, where I am currently posting on a near-daily basis physics tips for the ABR core examination. Without further ado, let's get into the questions and answers for this episode. First question: what subtypes of thyroid cancer classically may not take up iodine 131? On a board examination, if you are asked which subtypes of thyroid cancer classically are not radioiodine avid, the first I would remember is medullary thyroid cancer and the second anaplastic thyroid cancer. These subtypes may therefore not respond as well to I-131 therapy compared to other types of thyroid cancer. With medullary thyroid cancer, remember the MEN2A and MEN2B syndrome, that is multiple endocrine neoplasia, MEN, because MEN2A and MEN2B syndrome have an association with medullary thyroid carcinoma. Note also that medullary thyroid cancer has neuroendocrine features and may have uptake on an MIBG or octreotide scan, but may not have uptake on an I-131 scan. Papillary thyroid cancer is classically radioiodine avid. Next, what other factors contribute to treatment resistance of thyroid cancer to I-131 therapy? Can you list a few factors that may predict a poor response to I-131 therapy? Patients with prior I-131 therapy are more likely to be resistant, perhaps because resistant cells have been selected due to the prior I-131 therapy. So if you are going to retreat with I-131, you often have to significantly increase the I-131 dose for subsequent therapies. Additionally, prior methimazole treatment is also thought to possibly contribute to resistance to I-131 therapy. Finally, poor patient preparation, as we will discuss, can also cause too little I-131 to be taken up at sites of thyroid cancer and cause treatment failure. Next question: true or false? Thyroidectomy typically precedes I-131 therapy in cases of thyroid cancer. The answer here is true. Thyroidectomy is typically performed first, and I-131 is subsequently given to ablate any residual thyroid tissue. You may have heard this termed thyroid remnant ablation. First, you surgically remove as much of the thyroid tissue as you can, and then you turn to I-131 to ablate the residual thyroid remnant. It is not possible, even with the most skilled surgeons, to remove all thyroid tissue at surgery, so there will always be a thyroid remnant that can be ablated. There can also be variation in how much thyroid tissue remains post-thyroidectomy, so one can perform a thyroid uptake test with either I-123 or I-131, although I-123 is more common and perhaps recommended. And if thyroid uptake is something like 5% or greater, those patients may be at risk for thyroid pain following I-131 therapy and may be considered for something like steroid treatment during I-131 therapy to reduce symptoms, or even a return to the operating room to remove additional thyroid tissue if there is significant residual thyroid following attempted thyroidectomy. Next question. Do you want TSH to be elevated or low prior to I-131 cancer ablation therapy? TSH should be elevated prior to I-131 ablation therapy in order to stimulate residual thyroid tissue to take up as much I-131 as possible. You want the TSH to be really ramped up. You want those thyroid cells to be stimulated so these cells will take up as much as possible in order to get effective ablation. Two primary options exist to raise TSH values. The first is cessation of thyroid hormone replacement. After thyroidectomy, a patient may be on thyroid replacement, and prior to treating with I-131, you have them stop taking the thyroid hormone replacement. That will in turn stimulate natural TSH release from the hypothalamus as the body becomes hypothyroid. The second option is to remain on thyroid hormone and take recombinant TSH, which is also termed thyrogen. Note that a minimum TSH value of something like 30 is often considered acceptable prior to I-131 ablation, and a TSH value of 50 or higher may even be considered ideal. So you want really high TSH levels prior to giving I-131 therapy. Next question. What are common I-131 doses for thyroid cancer without nodal or distant metastatic disease, thyroid cancer with local nodal metastasis, and thyroid cancer with distal metastases? You really should know some basic values for ranges of I-131 doses. So to recap one more time, what is the dose for thyroid cancer with no metastatic disease, thyroid cancer with local nodal metastatic disease, and thyroid cancer with distant metastatic disease? Ranges may vary, but I think these values should serve you reasonably well on board examinations. I-131 for thyroid cancer with no nodal or distant spread will often be treated with a dose of somewhere between 50 to 100 millicuries. I-131 for thyroid cancer and local nodal disease in the neck would be considered for something like 150 millicuries, and I-131 dosage for thyroid cancer with distant metastatic disease may be something like 200 millicuries. Note that the dose can be calculated by more sophisticated methods that take into account things like thyroid uptake, weight of the thyroid gland, and so forth. Many centers have their own way of dosing this. I also would be aware that sometimes dosimetry may be performed in which an expert at radiation dosimetry with I-131, such as a nuclear or radiology physicist, will evaluate what dose is appropriate. That can be really beneficial for things like diffuse thyroid cancer lung metastases, to make sure you are finding an optimal balance of dose where enough is given to give therapeutic effect, but not too much is given in order to prevent something like lung radiation fibrosis, if a lot of the I-131 is expected to end up in the lungs at sites of thyroid cancer. Next question. What are general dose ranges of I-131 for therapy of Graves' disease, autonomous hyperfunctioning thyroid nodule, and toxic multinodular goiter? For Graves' disease, you often would treat with something like 5 to 15 millicuries of I-131. Autonomous hyperfunctioning thyroid nodule may often be treated with something like 15 to 25 millicuries I-131, and toxic multinodular goiter is often treated with something like 25 to 35 millicuries of I-131. So again, Graves' disease has the lowest typical dose of 5 to 15 millicuries. Autonomous hyperfunctioning thyroid nodule comes next with 15 to 25 millicuries, and toxic multinodular goiter would come next with something like 25 to 35 millicuries. Next question. What are common precautions that individuals must take prior to I-131 therapy? The list of potential precautions that an individual could be instructed to take prior to I-131 therapy is somewhat lengthy and varies somewhat between site to site. But some general things to keep in mind for board exam purposes is that following I-131 therapy, a patient must isolate for something like 3 days from other individuals, including things like having a separate bathroom and performing excellent bathroom hygiene to prevent contamination from radioactive urine, sleeping alone, and avoiding exposure to others from bodily fluids, including saliva and urine. Additionally, patients should stay well hydrated. There may be certain dietary precautions that are recommended prior to I-131 therapy and so forth. I think I've covered some of the most commonly tested here, which would include things like sleeping separately for 3 days, avoiding sharing the bathroom, and other activities that can potentially expose others to saliva or urine that may have the I-131 within the fluid. Next, what is an estimated risk of malignancy from a single cold nodule on a radioactive iodine scan? A single cold nodule has an approximate 15 to 20% chance of malignancy. Note that the risk of malignancy increases if a cold nodule is seen in a younger patient, if a nodule is hard on palpation, or if there is a history of neck radiation or family history of thyroid cancer. Key for board exam purposes is to remember that a single cold nodule has an approximate 15 to 20% chance of thyroid malignancy. Next, what is the estimated risk of malignancy from a hot nodule on a thyroid scan? In general, the risk of thyroid cancer in a nodule that is hot on a radioactive iodine scan is thought to be less than 1%. Next question. Is hypothyroidism common in patients with toxic multinodular goiter following I-131 therapy? The answer here is no. Hypothyroidism typically is not expected in patients with toxic multinodular goiter following I-131 therapy. In toxic multinodular goiter, the radioactive iodine preferentially is taken up into the toxic nodule or nodules, and the remainder of the gland is suppressed and will have suppressed uptake of I-131 and is therefore not ablated. Note that many of these patients with toxic multinodular goiter actually may end up becoming euthyroid following I-131 therapy, so that can really be ideal that you can treat with I-131, resolve the excess thyroid hormone in the body, and end up in a euthyroid state. The same principle would also hold true for a hyperfunctioning thyroid nodule if the thyroid nodule takes up the majority of the I-131, and because that nodule has been hyperfunctioning, the background thyroid is subsequently suppressed, and the radioactive iodine is preferentially taken up within the nodule and preferentially ablates the nodule, sparing the normal thyroid parenchyma and potentially ending up in a euthyroid state. Next question. How can one differentiate between a Technetium 99M Protagonate scan versus a radioactive iodine thyroid scan? One key is that if you see higher salivary gland uptake than thyroid uptake, and you may see a lot of background counts, then the scan is more likely to be a Technetium 99M scan. A radioactive iodine scan would show robust thyroid uptake with little background uptake, and thyroid uptake would typically be above the salivary glands. Next question. What should you consider if thyroglobulin levels are rising in a patient who has completed thyroidectomy and I-131 ablation for thyroid cancer, and the I-123 or I-131 thyroid scan is negative? Also, what would be the next best test to consider? In this setting, with a rising thyroglobulin level and negative whole-body thyroid scan imaging in a patient with thyroid cancer that has previously been treated, one must consider the possibility that the thyroid cancer is truly back, as evidenced by a rising thyroglobulin level, but the thyroid cancer has dedifferentiated and therefore no longer takes up radioactive iodine. In this setting, one would want to perform an FDG PET-CT study to show where the site or sites of recurrence are located, because a dedifferentiated thyroid cancer would be expected to be FDG avid. There is a trade-off here between lower grade or better differentiated thyroid cancers being the cancers that do take up radioactive iodine versus dedifferentiated thyroid cancers that no longer take up radioactive iodine but become very FDG avid. And this is a somewhat common scenario that can be tested on board examinations. Next, what type of collimator is best for I-131 imaging? For iodine-131, a high-energy collimator is used given the very high 364 keV energy of I-131. If lower energy collimators are used and you are imaging I-131, you would expect to see septal penetration with the characteristic star-like artifact that is classic for this entity. If you do not know what septal penetration looks like, you need to look this up. It is commonly tested, and it is most commonly seen and tested in the scenario of I-131 imaging when using a low-energy collimator, and those 364 keV gamma rays have no issue penetrating the septa, causing that classic star-like artifact. Note that I-131 is basically the highest energy radioisotope that is commonly used in general nuclear medicine for imaging. Next, besides thyroid imaging, can you name another nuclear medicine scan that uses either I-123 or I-131 as the radioisotope? First of all, MIBG can use I-123 or I-131. One therefore needs to block the thyroid gland before an MIBG scan to prevent unwanted thyroid uptake. Lugol's, L-U-G-O-L-S, Lugol's iodine solution is commonly used prior to imaging with MIBG to prevent unnecessary radiation to the thyroid. Remember to block the thyroid first prior to MIBG imaging. That is very important, especially when imaging pediatric patients with MIBG and when using I-131, because you definitely do not want to ablate any of the child's normal thyroid. Additionally, a dual tracer technique for parathyroid imaging can also be performed where I-123 is given to show background thyroid uptake. That is then subtracted from a Technetium 99M sestimib or thallium-201 chloride scan that is taken up more so by the parathyroid glands, with only some background thyroid uptake. If you then subtract the I-123 thyroid image, you are left with uptake primarily from the parathyroid glands. Lastly, DAT scan uses I-123 ioflupane. So I-123 is also used for DAT scan imaging, which is dopamine transporter imaging. Note that Octreoscan, O-C-T-R-E-O, Octreoscan, uses indium-111 and not iodine-123. That is something I used to confuse as a radiology resident. Next, what is the concept of thyroid stunning? Thyroid stunning is a reduction in I-131 uptake below predicted values that can follow a low-dose diagnostic I-131 scan. The thought is that either reduced cell function and or cellular death following a diagnostic I-131 scan, such as an I-131 whole body search, can subsequently lead to reduced therapeutic I-131 uptake due to the stunned thyroid cells secondary to the initial I-131 low-dose study. Next question. Approximately how long should you wait following IV iodinated contrast administration to treat a patient with I-131? Following intravenous administration of iodinated contrast materials, such as for a contrast-enhanced CT scan, a patient should typically wait something like 6 to 8 weeks before being treated with I-131. The problem is that the iodinated contrast can saturate the thyroid with iodine, and you therefore would have less uptake of the radioactive iodine and may have a treatment failure or poor treatment response from the I-131 administration. So wait 6 to 8 weeks following a contrast-enhanced CT before you would treat a patient with iodine 131. Final question for this episode. What are NRC Nuclear Regulatory Commission guidelines for releasing a patient following I-131 oral administration? Things to remember are that first, no individual of the public should receive more than 5 millisieverts exposure from the patient treated with I-131. Second, a patient may be released when a survey meter reading at 1 meter is less than 0.07 millisieverts per hour, which is the same as 7 millirems per hour. That is really important and can definitely be tested. Remember that 0.07 millisievert per hour survey meter reading at 1 meter prior to a patient release. And third, when the administered activity is 33 millicuries or less, the patient may be released. Importantly, prior to release, an authorized user should instruct a patient who received I-131 regarding best practices to minimize radiation exposure to others and provide some sort of written instructions describing the recommended methods to limit radiation exposure to others. Precautions include having the patient sleep alone, avoid being around pregnant individuals and children, avoid public transportation, follow strict bathroom hygiene, and so forth for about 3 days. Remember also that I-131 exposure can occur through bodily fluids, but not through physical touch. For example, if you are asked on a board exam if a family member should worry about touching something like a door handle that was recently touched by the person who was treated with I-131, you can confidently answer that that is not an issue. I-131 does not spread by touch. It does spread by bodily fluids such as saliva and urine. That is enough for now. I will post the study guide on the last 3 episodes on nuclear medicine and the thyroid on my website, so check that out. I also have a few links for articles at the end of the study guide that you can check out for additional information on nuclear medicine and the thyroid, including iodine 131 therapies, if this is something that you would like more information on. Thank you for listening to this episode. I hope this was helpful for many of you. Remember to study hard. You have to study really hard to succeed on radiology board exams. So prepare to succeed. I will catch you on the next episode. Content of this podcast is provided for informal educational purposes only for radiology trainees and radiologists. Medical practitioners, please make your own independent assessment before suggesting a diagnosis or recommending any course of treatment. This podcast should not be used for self-diagnosis or self-treatment and is not a substitute for independent professional medical care. Please consult your own physician regarding any diagnosis, imaging interpretation, or course of treatment.